Before I move on to the course itself, I'd like to invite my co-instructors, Dr. Praveen, who is a consultant at CFS on the dais, Dr. Kumar Ravi, he'll be joining us shortly, Dr. Silpi Agrawal, who is consultant at Lakshmi Netralaya at Patna and a trained glaucoma fellow, Dr. Manish Singh, director and faculty consultant at Netralayam, super specialty, also treasurer of the GSI, Dr. Mamta Singh, who's assistant professor at All India Institute of Medical Sciences, Rajkot. Dr. Ravi will be joining us. So let's move on to the course itself. So the primary objective of this course is to identify the mistakes and the reasons of the glaucoma failure and glaucoma treatment failure as well as diagnostic failures, and then build up our treatment protocol for the betterment of the patient vision and the patient outcome, visual outcome. So glaucoma being the second leading cause for the blindness worldwide and in India also. And early diagnosis and treatment is essential to prevent the glaucoma and its accompanying loss. Slide is not moving. Excuse me. Yeah, it's moving now. So why failure is important? Because this is a chronic disorder. Usually failures are bound to happen, and identifying the failure at appropriate time is going to save the visual life of the patient. It is also distressing for the treating physician as well as the patient when failure occurs in the treatment or in the outcomes, whether it is diagnosis, medical laser treatment or surgical management. The failures are really hurting in these cases. The objective of this course is to make the attendees identify the reason of failure and way to fight in order to make the quality of the patient vision. So these are my co-instructor, and they'll be dealing over the medical management, laser procedures, surgical failures, and patient quality of life during the course of this talk. So coming to my talk, glaucoma is sneak thief of sight, no symptoms, very gradual loss of vision, no cure, only control is there. What Lancet has said in the recent article that glaucoma was the ranked second leading cause of the blindness and also the most common cause of irreversible blindness and the second most common cause of irreversible moderate to severe visual impairment. Estimated to be 27.8 million people by 2040 in Asia. India and China will share the maximum burden, equal proportion of the open angle and the closed angle glaucoma, responsible for 5.9% of blindness, and 90% of the glaucoma is undiagnosed. That's a huge number. So it is defined, so if we based our definition based on the visual acuity criteria instead of the visual field, which are definite criteria for glaucoma, every 8th individual of the nearly 40 million of the estimated 309 million population, is it 40 or older in the India, either has glaucoma or at the risk of developing the disease. So there are certain surveys available with us, like APDIS, Andhra Pradesh Eye Disease Study, Arvinda Comprehensive Eye Survey, Vellore Eye Survey, and Chennai Glaucoma Survey, which throws some light on the actual prevalence of glaucoma and the findings prevailing in the society. So what Andhra Pradesh Eye Disease Study says, 11,786 subjects were enrolled, and what was the outcome? Outcome was definite POAG in 2.56%, suspected POAG in 1.1%, OST in 0.42%, and again 92.6% were undiagnosed. In PACG also 66.6% were undiagnosed at the time of survey itself. So you can very well comprehend what is happening in the community. Next study was Arvinda Comprehensive Eye Study. Again, 93% patients were previously undiagnosed and 2.6% was the glaucoma prevalence in these cases. In Vellore Eye Study, routine gonioscopy was incorporated into the survey tools, and that shows that once you incorporate gonioscopy into your tool, what is going to happen? The prevalence of PACG increases to 4.32%. So unsuspected high prevalence of primary angle closer glaucoma was present in the society. That means you have to incorporate gonioscopy in your routine practice. Now, the next study was Chennai glaucoma study, and patients who have undergone cataract surgery were at high risk, because these were the patients who were, the patient enrolled were basically for glaucoma in cataract operated patients. So this is the summary of the different studies. The most important finding out of those surveys were undiagnosed, large volume of undiagnosed cases. Good number of angle closure diseases were present if you incorporate gonioscopy into your practice. Another study from this part of world, that Hooghly study, was total 14,000 patients were participated, and 2.7, this was having urban as well as rural arm, and 2.7% were detected to have glaucoma in the rural arm, whereas 3.23% in the urban arm. So significant number of POG had IOP within normal range. 90% of the POG and 70% of PACG were diagnosed during the survey. Prevalence of angle closure glaucoma was high. And then gonioscopy is essential in all the patients. So what are the critical challenges when we have to diagnose this large volume of the glaucoma patients? Since there is low level of awareness, undetected and undiagnosed cases, poor access to the glaucoma diagnostic and therapeutic services, and issues related to compliance with the treatment. So what should be the basis of a screening test? Mass screening we can do, but that's not possible in the volume which we have, the kind of population which we have. So selective screening and opportunistic screening are the two tools which we can employ for detecting these high number of undiagnosed cases. So the suspected cases are age more than 40 years, family history of glaucoma, diabetes, hypertension, steroid, colored halos, frequent changes of glasses, myopia and headache. These patients need to be evaluated. Having said that, all the patients coming to your OPD need to have a fundus, the disc evaluation done, as well as IOP evaluation done before we move on to the next level of evaluations. So every patient beyond 40 years need to have a screening for the glaucoma, and more so in cases of suspected patients. So which tests should be employed? Community level screening glaucoma is challenging task. To screen for glaucoma has no definite proven or even a consensus answer. So IOP can be one tool, but it's not possible. Short functional test of the different kind, like visual field estimations, is also not feasible for the community testing. Howsoever, the out-of-box screening tools now available with a shorter testing time, the disc analysis through a picture, the tools with artificial intelligence are available, which can sort out, which can actually pick up those unsuspected missing cases from the society, and that need to be used for the screening of the patients in the society as such. So primary level, we have to train the general practitioners and ophthalmic assistant, and the ophthalmic assistant need to be trained and need to be incorporated in this fight against glaucoma to identify maximum number of cases from the society. Secondary level is applanation tonometry, screening of family members and complicated cases has to be done. Tertiary level, we have to build up the capacity building has to be done. So to conclude, ignorance is not a bliss in glaucoma blindness. Opportunistic screening of all 40 plus patients attending IOPD need to be performed. IOP, gonioscopy, optic disc evaluation should be part of routine examination, and the tools which are available right now with artificial intelligence can be used in the society for screening at PSC level or CSC level or even at the basal levels, and glaucoma awareness campaign has to be performed. So with this, I come to conclusion of my talk. I'd like to invite now the next speaker, Dr. Praveen, who is a faculty and consultant at CFS Patna, a trained person from JIPMER, Pondicherry. He'll be talking on under and over diagnosis, the failure of machines or the man behind the machine.
So good morning. My topic is under and over diagnosis, failure of machine or man behind the machine. So, to define glaucoma, glaucoma is a chronic progressive optic neuropathy characterized by topical optic nerve head appearance with correlating RNFL defect, correlating visual field, and for this, IOP is the most important risk factor. I think we are in the privileged world because we are having so much of machine and technology, but before using these machines to diagnose any kind of disease, we should know about the machine, we should know little kind of software and algorithm about the machine. So, in day-to-day clinical practice, it is not uncommon to see glaucoma in non-diagnosed glaucoma cases, and also patient is on over-treatment, patient on treatment, and those patients are actually not having glaucoma. So, to look the prevalence worldwide, approximately 50% of the glaucoma patient are overly diagnosed and was on the anti-glaucoma medication, and also the 50% of the patient are under diagnosed. India is not apart from this, and India is having 90% of undiagnosed glaucoma. So, and this issue are getting more complicated for those patients who are non-compliant and who are on not regular follow-up. So, what could be the effect of the overdiagnosis and underdiagnosis? Underdiagnosis of the glaucoma will lead to progression of the disease, and ultimately it will lead to blindness, and overdiagnosis will lead to the overtreatment, which will cause the financial burden, also the psychological burden to the patient, and it will cause side effect related to the drugs also with the preservative. So, what are the factors contributing to the overdiagnosis? It will be the fear of loss of vision, reliance on the newer diagnostic tool, misinterpretation of the test report, introduction and marketing of the newer molecules, like so many drugs are about so many drugs it is told that is neuroprotective agent, but still it is under debate, and also not last and the least medical legal concern. What are the factors contributing to the underdiagnosis? Also, it is the patient-related, like lack of awareness and inaccessibility to the health facilities, and also the ophthalmologist-related, like lack of resources. So many of the clinics are running on the short tonometer, and in the busy OPD, it is sometimes difficult to look for a comprehensive eye examination. So finally, who is responsible? Either machine or man behind the machine. So in this instruction course, I will be discussing about this. So it is very important for almost all the patient to do a comprehensive eye examination, which will include the slit lamp biomicroscopy, detailed fundus examination, including the assessment of the optic nerve head, gonioscopy, and measurement of the IOP. In suspected cases, we must do Goldman applanation tonometer, and if we are suspecting or we are diagnosing glaucoma patient, we should do OCT and visual field analysis. So various study has shown prevalence of undiagnosed glaucoma is more than 50%, and in this study, there is a telescopy eye study. In that study, it was self-reported glaucoma, which was having prior diagnosis of glaucoma, who was on the previous medical or surgical treatment. The prevalence was 2%. But when this study has included those patients who are having high pressure, high IOP, then the prevalence was raised from 2% to 5.5%, and surprisingly, 60% of those patients were not confirmed on subsequent analysis or detailed analysis. So when these glaucoma patient will be misdiagnosed, either IOP is high or in the normal range. So any kind of high IOP, or if we are suspecting glaucoma in normal IOP patient, we should do intraocular pressure measurement, definitely by applanation tonometer, and this IOP should be correlated with the pachymetry, because we have to adjust the intraocular pressure with central corneal thickness. Second is, and I think this is the most important part, assessment of the optic nerve head and the retina. And most of the time, glaucoma was misdiagnosed based on the increased cup-disc ratio, and about 20% are misdiagnosed and inappropriately treated as glaucoma when that diagnosis is based on the large cup-disc ratio. So in the optic nerve assessment, we should look for the size and shape of the disc, cup-disc ratio, neoretinal rim, nerve fiber layer abnormality, retinal fiber hemorrhage, and peripapilar atrophy. So in this nice picture, we can see cup-disc ratio is increasing, but the disc is non-glaucomatous because neuroretinal rim is healthy. But in this picture, we can nicely see this one is a small disc, but it is having inferior RNFL defect. This is almost 0.6, 0.7 cup disc ratio with inferior retinal fiber layer hemorrhage and subsequent NFL defect. And this is also around 0.8 cup disc ratio with inferior notch and nerve fiber layer defect inferotemporally. So it is very important to look for the disc very carefully, and it is important to, for documentation, we should do the fundus photography also. Optic coherence tomography, I think this is the most important and most commonly used tool in day-to-day practice, and this is used for the diagnosis as well as the follow-up of the glaucoma patient. But before using the OCT, we should know about the anatomical as well as the physiological variation of the disc, like previous instruction course, the myopia patient was discussed. So we should know the anatomical variation of the optic nerve head also. So based on the OCT, there is a disease called as red disease and green disease. Red disease are those diseases which are falsely positively diagnosed glaucoma due to incorrectly indicating the red in the corresponding image when there is no damage. And the green disease are false disease diagnosed when the software interpret actual glaucomatous damage as normal picture. Like in this, we can see this is the increased cup disc ratio around 0.7, but neurotelrim is healthy, but OCT is showing the red disease. Like in the left eye, we can see the red picture in the left eye temporally. Green disease, like this in the right eye, we can see the inferotemporal small RNFL defect, but the OCT is showing the normal picture. This is called as green disease. Subsequently, the visual field is used to diagnose glaucoma. Also, we will able to see whether it is stable or not. So in the visual field analysis, we have to look for whether it is normal or abnormal, which is based on the p-value. If it is abnormal, it is disease or not, which is based on the prior probability. And subsequently, if any visual field defect is there, we have to correlate with the optic nerve head finding. Like in this picture, we can see the optic, this is the visual field defect, superior dense arcuate scotoma, but the optic nerve head was healthy, and actually this is because of the ptosis, and when the visual field was reperformed with taping of the upper lid, the visual field was normal. This is also a visual field analysis of the inferotemporal VRVO, which is showing the superior arcuate scotoma. So how to prevent over and under diagnosis of glaucoma? We have to increase the public awareness. Comprehensive eye examination is compulsory. Judicious use of the machine. Proper infrastructure and training should be there. And evidence-based approach also should be there. And also there is regular eye examination. So nowadays we are living in the privileged world that we are having so many machines. So we should use machine judiciously. When we have to use, how we have to use, it is depend on the man behind the machine. So it is upon us how we are using the machines judiciously. Thank you.
Thank you, Dr. Praveen. In fact, it is very important to understand that the clinical correlation with all the findings on the tools which we are using need to be there in order to make a proper diagnosis. If there is discrepancy between the clinical finding and the findings which are present on the instrument which you are dealing with, then you have to revisit your clinical findings again. Any what do you want to put?
I have a question here, sir.
Yeah.
Recently, I came across a patient where the visual field parameters, like where the reliable field, it was showing a normal field. No, the OCT was normal, but visual field defect was there. So where exactly the things, I mean, how to go ahead with this? And we repeated this test like over a period of a month, getting consistent result.
I think we should look for the optic nerve head first, whether it is correlating with the field or not. Sometime, most commonly, nutritional optic neuropathy or toxic optic neuropathy is showing the central scotoma because of the loss of the papillomacular bundle. In such cases, the optic RNFL OCT is almost normal. But when we are doing the GCIPL in OCT, it is completely showing the loss of the papillomacular bundle. Again, in this, we can differentiate whether it is because of the diffuse loss of the papillomacular bundle in GCIPL. But in case of the glaucoma, when there is a loss of GC-IPL bundle, there will be a Raffi sign, that is complete demarcation from the superior arcuate and the inferior arcuate, even in the OCT also. So even if such kind of patient we are seeing, we should, I think we should correlate with the optic nerve finding with OCT and with visual field.
One more important thing in these cases, I think, is constant follow-up. If the clinical finding is not correlating with the visual field, then we have to see whether there is any progression or not in due course of time. If there is progression, then naturally we have to deal with the case. You want to add something?
Field
is
was
there.
normal.
Field defect is present.
Field defect was there, but OCT was normal.
So I think I'll agree to both, I think Bibhuti sir and Dr. Praveen. So if the pressures are normal and your disc is appearing healthy, you can just keep under 6 monthly follow-up and we don't need to treat. And just doing a basic investigation to exclude any neurological cause or ischemic cause will be helpful for these patients.
Right. And in general, like this is the group where we find all these vasculopathy also. Like if there is a case of BRVO, right? So old BRVO, suppose if we have, how reliable is OCT RNFL in these cases? Like,
Not very reliable, because if there is a localized area of BRVO or a scar, those areas you will have a chorioretinal atrophy, and associated in those areas you will have a RNFL thinning also.
yeah, right.
So a lot of these patients will show RNFL thinning corresponding to the area of BRVO. In this case, you can't use OCT for diagnosis, but if you're following up this patient and you're seeing disc changes or a progressive thinning
Then it would
in the
matter.
OCT, then it may be of some help.
So moving on to the next talk by Dr. Kumar Ravi, who was ex-faculty and consultant of Sankar Netralaya, Kolkata, and now faculty at Netralayam. He'll be dealing with medical management, failure and way out. Welcome, Dr. Ravi.
Thank you. Thank you, Dr. Bibhuti, for having me in this IC. And I will be discussing about medical management, failure and way out. And I have little different kind of presentation. All my points which I have to discuss will be in case format. So I have no financial interest. Coming direct to the topic, first case. My patient was a 46-year-old male. He was a diagnosed case of primary open-angle glaucoma, and he was on 2 anti-glaucoma medications, prostaglandin analogs with combination. And he was on follow-up, and his IOP was 24 and 22 millimeters of mercury. But then the expected IOP was 16 millimeters of mercury. So why is he having high IOP? Is the medicine not working? So first important thing is to know about the compliance thing. The patient admitted that he missed drop thrice in last 1 month. But if we dig into it, okay, we'll come to know that the situation may be very different. There's an article which says that patient might have missed 24 to 25% of their prescribed drop. Okay, and this they have done via study. They have done a gyroscopic sensor they have attached to the drop, which measures whether the patient has picked up the drop, whether it has been tilted. That means they're trying to verify whether the patient has used a drop or no. And what they found was that the patient is telling that he has missed 3% of the times. Probably he has missed the drop 24 to 25% of the times. So my patient might have not put the drop for maybe 1 week in last 1 month. And this is common story with most of our patients. So if the patient is not using drop, the drop is not going to work. So this is my first message. The commonest cause of medical therapy failure is poor compliance, and glaucoma drops don't work when not used. Coming to second case, again, this patient was a 39-year-old lady. She was referred for left eye trab, and at presentation she had a high IOP of 22 millimeters of mercury on 3 anti-glaucoma medications. I have a disc drawing of this patient which shows that left eye, the disc is definitely glaucomatous. And she was noted to have open angles in 2013. The patient is having high pressure on 3 medications. That means probably she will require a surgery. So before going for surgery, I thought of doing a full evaluation. Her pressure was definitely high. Disc asymmetry was present. But gonioscopy, there was 360-degree closure with few synechiae. And then it was opening with indentation, with deep indentation. So basically she required was first a YAG PI. I did YAG PI and observed her again after 1 week, and the pressures were normal. And after 1 week follow-up, now she's almost on 3 years follow-up, the pressures are normal after PI without any medication. So basically angle closure disease medical management has a role, but that should be after PI. Once we have done PI, then many of the patients may not require medical management. Now, a similar case, something similar to what we have seen in case 2. This was a 42-year-old male. He was seen in 2017. The pressures were high. He had a little bit of disc asymmetry, and YAG laser was done for angle closure glaucoma. But after YAG laser also, the patient was seen that IOP was going up in 1 week to 3 months. He required 4 anti-glaucoma medications to control the pressure, and the pressure was still high. So here we have a patient who has a YAG PI done, PI is patent, still pressure is high. That goes towards diagnosis of plateau iris syndrome. So if we have a patient with patent PI and high pressure, suspect plateau iris syndrome. And we have many postgraduate students probably here. So what would be the drug of choice when we have a plateau iris syndrome patient? So basically, we have to give them pilocarpine. Okay, so it's a less commonly used drug nowadays. So for this patient, I started pilocarpine in OPD itself, and the pressure came down from 36 to 16 within few hours. So ultimately, we could reduce drops one by one. And in the last follow-up last year, the patient is on single drop pilocarpine and is doing well. 10 years follow-up, field changes are virtually not there, almost stable fields. Now, correct diagnosis and drug of choice makes the difference. Coming to the next case, it's a 19-year-old young patient, very high pressures, was on maximum medication with tablet acetazolamide, with history of anti-uveitis in the past. Now, when we observe this patient, angles are open, CDR is okay, but pressures are very high. He told that some injection had been given to his eyes. Initially, we thought that probably anti-VEGF injection maybe for some reason has been given, but when we looked inside properly, we saw that it was subtenon steroid depot injection. So because of steroid-induced glaucoma, he had a very high IOP, and this was done bilaterally, so both eyes pressures were high. So if we have a patient of steroid-induced glaucoma, the first thing that we have to do is to remove the steroids. If the steroid, say in the form of depot or injection or tablets, if it is there, pressure will not come down whatever medications we use. In this case, one eye we removed surgically, and other eye with medication we could control, and slowly that steroid depot dissolved. So coming to the next case, this was a 59-year-old patient with high IOP on maximum medications again, with recent onset of redness in the left eye. There were no other history or complaints. So if you see this patient, left eye, there's a engorged blood vessels, and if you see carefully in the angles, you will see that the Schlemm's canal has blood there, this area. So something more than a basic glaucoma. When we did imaging and detailed investigation, we found that she had keratoconus cavernous fistula, and the patient was referred for proper treatment of fistula, following which the glaucoma symptoms automatically resolved. Now, in unilateral high IOP with red eye, please suspect something else. It will not be just angle closure glaucoma or open angle glaucoma. It could be, say, traumatic glaucoma, CCF, or proliferative diabetic retinopathy changes leading to secondary glaucoma, or something will be there. Once we treat this underlying cause, the patient may require minimal medical therapy, or sometimes they do without therapy also. Without therapy also, the IOP is under control. Now, this is a very interesting case. This is a young boy, 12 years old. He had allergic conjunctivitis, and he was on long-term treatment with multiple therapy, and he was referred for glaucoma evaluation with the pressures of right eye 16 and left eye 2. It's not spelling mistake, it's actually 2 pressure. So when I evaluated again, I saw that yes, it is correct. Patient is having glaucomatous disc with IOP of 0. I was getting a pressure of 0. And treating doctor had withdrawn the anti-glaucoma medication 6 months back, thinking that this is not glaucoma, pressure is 0, how can it be glaucoma? We rechecked it, actually we're getting 0 pressure. Now if you see the pictures carefully, there is a central scar. So because of maybe shield ulcer or something, this patient had a central scar. And if you see the corneal curvature, the curvature was not the typical corneal curvature. There's a flattening over there. Because of this flattening in the corneal curvature, the pressures were coming as abnormal. With all instruments, we're getting abnormal pressure. But at least in these patients, we can do disc evaluation, we can do perimetry, and they were all suggestive of glaucoma. So my take on this is irregular corneas, we can get false pressure. This can be because of multiple reasons, maybe trauma, maybe some scar in the past. So IOP alone does not define glaucoma. We can do a proper disc evaluation and visual fields maybe 6 months or yearly, and then follow up this patient. This particular patient, we followed up on 2 anti-glaucoma medications, and the patient is stable. Coming to another case, 56-year-old male. He was having stable glaucoma with pressures in the range of 16 to 19 and was stable for last 6 months. But in one particular follow-up, the pressure shot up to 24 and 26. This can happen in our glaucoma patients. Like say if you have 100 patients following up for glaucoma, 1 or 2 patients may actually show progression even on the stable therapy that we are using. So the patient had borderline IOP. We kept him on close follow-up, but we need to add medications in these patients because they can be a slow drift, especially seen in beta blockers, but in other medical therapy also there can be a slow drift in IOP. In some cases we need to add medication, but remember that when we are adding medications, they can be non-responder. The patient may not respond to therapy. Suppose we add anti-glaucoma medication over and above the one that we are using now, say at the pressure of 26, and in follow-up we see that the pressure is again 26 or 27. That means the drop we have added is not working. So we need to look into alternatives. Now coming to another interesting case, 46-year-old patient diagnosed with angle closure. He was started on anti-glaucoma medications after PI and was started on brimonidine. This is very unusual case. Okay, may not see day-to-day basis in clinic, but yes. After starting brimonidine, he's developed AC reaction, cells and flare. This is a very uncommon thing, but anti-glaucoma medication sometimes can cause AC reactions, and this was causing increased pressure. Initial pressure was 26, and after starting therapy, it was 38. So there are instances when glaucoma medication itself can induce high pressure, but these are rare instances. Now, all medications have side effect, and we have to select one that we require with tolerable side effects. Then there are a group of patients, mixed bag cases, like say congenital glaucoma or lens-induced glaucoma, in which let us not go into the medical management. These are all direct surgical cases. Towards the end of the presentation, medical therapy doesn't work if patient misses drop, if we miss a diagnosis, if there is a improper follow-up of IOP and HVF. Glaucoma is usually a slow progressing disease. It will give us multiple opportunities to take corrective measures, and we should be prompt in picking up time for intervention. The take-home message, medical therapy of glaucoma needs us to ensure patient compliance, not miss annual gonio, 4 to 6 monthly checkup, and disc and field evaluation. Glaucoma glaucoma offers multiple opportunity for course correction, and we need to pick up the signs and then switch as and when required. Thank you.
Thank you, Dr. Kumar Ravi, for this wonderful bouquet of interesting cases, and that has conveyed the message when we have to look at the failures. So if failure occurs during the course of treatment, then we have to revisit our diagnosis, we have to revisit the compliance issues of the patient, and also any other changes which are developing, newer things developing into the patient that need to be taken into consideration. We'll have questions later on. So we move on to the next talk by Dr. Silpi Agarwal. She's a trained fellow in glaucoma from Arvinda and now consultant at Lakshmi Netralaya at Patna. She'll be talking on laser procedures as stepping stone. So why laser? Because we know that when treatment starts failing in medical management also, so there are a number of different lasers available right now. She'll be talking on that.
Good afternoon all. Thank you, Dr. Bibhuti sir, for giving me this opportunity. We all know the moment we diagnose glaucoma for a person, it will change patient's life. It's not only in terms of economic burden, but it also steals the mental peace of a person. It's all because of the chronic nature of the disease. The term lifelong for a glaucoma actually hurts a lot. So the medical management of the glaucoma relies heavily on the patient's compliance, as Dr. Ravi already discussed, which is very inconsistent. Many a time, the undesirable side effect of the drug impacts patient's life and the patient's comfort and the quality of life. So a lot of time, laser is bridging between the medical and the surgical management, as it is minimally invasive and is better in achieving target IOP by altering the drainage system of the eye. The better control of the IOP will slow down the glaucoma progression and improve patient outcome. There are many options are available for the laser treatments are available, but the correct selection of cases and the diagnosis of a type of glaucoma is essential for the success. The laser patients are evaluated at multiple levels from pre-procedural evaluation to identify the potential risk complications of the lasers. So when we're comparing the traditional laser procedure with the medical management of glaucoma, the study reveals that the laser is equally efficient. Moreover, it is one-time procedure and require very minimum post-laser reviews and medications. The high safety profile of the laser is due to our recent understanding of cases and the selections of laser parameters. It is equally cost-effective, and even it is a cost-effective than the normal glaucoma surgery and the medications. So, discussing all this reason, the laser is considered as a stepping stone in the glaucoma management. There are multiple lasers options available, but the most commonly used is the anti-yac peripheral iridotomy, where we are creating a small hole in the periphery of the iris using a laser to improve the flow of aqueous within the eye to relieve the pupillary block. These are the indication, but one should know when this laser is not going to work. The laser iridectomy, if the angle is shallow, is not due to the pupillary block mechanism. Means to say, if it is non-pupillary block mechanism is there, all those cases the PI is not going to help, like the AC shallowing by the lens-induced AC shallowing, and if young myopic patient who is on antipsychotic like the topiramate, which here the shallowing is due to the choroidal effusion and shallowing, the PI is not going to help. The laser works on the principle of photo disruption. Sometimes when we are saying that the iris is really very thick, or the patient is on anticoagulant for a quite long time, that risk of bleeding is high during the laser or post-laser. In all those cases, we first try the argon laser, which attenuates the iris to 1/4 of its original thickness and is also coagulate the nearby vessel. And in the very second sitting, we can go ahead with the YAG PI to make it the PI patent. The best site for the laser to do is 11 to 1 o'clock hour, but we can do anywhere where we can find the good crepe. The pilocarpine is used to make the eyes moist, and the paracaine is used just to numb the eye just before the laser. Abraham lens is the lens of choice, as it reduces the energy delivered to both cornea as well as retina by almost 4 times less than the Weiss lens. This slide is just showing the comparison between the argon and the anti-YAG laser. Post-laser, the steroid drops are used for 7 days to reduce the post-laser inflammation, and the anti-glaucoma just to reduce the post-laser spikes. Patient is recalled for the checkup after 7 days to see the IOP and to check the patency of iridectomy. Even some of the cases we are saying, even with the patent PI, the IOP is not controlled. All those cases maybe the glaucoma is of combined procedure, which need either medication or performing iridoplasty to separate the adhesion from the angle wall and to open up the potentially functional trabecular tissues. The most common problem with PI is the bleeding, which is usually is easy to handle. You just pressing the gonio lens over the iris, or just giving the pressure with thumb. Now coming to the laser which is stealing the global attention, that is the selective laser trabeculoplasty for open angle glaucoma. These are the common indications. This laser use is a frequency double Q switch anti-YAG with a spot size of 400 micrometer. The SLT causes the selective photothermolysis by targeting the pigmented melanin cells in the trabecular meshwork. The way it works on a very short pulse duration to prevent the thermal damage to the surrounding tissue. The mechanism of action of this SLT is by the triggering of macrophages, which engulf the damaged trabecular meshwork cell and also proliferate the healthy trabecular cell on the lost area. this slide just shows the size, the ALT, which is deliver the energy of almost 2 to 300 times more than the ALT, which causes the thermal damage, the coagulative thermal damage, as compared to SLT, where there is a minimum thermal coagulative damage of the trabecular meshworks. These are the some contraindication where SLT is not going to work. This slide just showing the size difference of SLT. SLT, the size is around 400 microns, so we just need to hit the angle. We not need to be very precise as compared to the ALT, where the laser is put on the anterior trabecular meshwork. In 2019, the light trial is carried out in Moorfields Eye Hospital, was published in the Lancet Journal. This multi-center randomized controlled trial of drop versus SLT confirmed the effectiveness of the SLT and concluded that the SLT should be offered as a first-line treatment for open-angle glaucoma and ocular hypertension. They also say that if the IOP is not controlled with the medication, it should be adjuvant with the medication so that the need of surgery should be delayed. Now coming to the destructive procedure, which earlier is thought to be the last resort, but now we are doing in the seeing eye also. Earlier the cryo laser are used, but now it is replaced by the diode CPC. So the indication for the cyclodestructive is all kind of refractory glaucoma as well as is the secondary glaucomas. The peribulbar anesthesia is given because it is a painful procedure. The one thing one should be noticed that marked is the written consent. The patient should be well explained about the consequence of the laser, this destructive procedure, because now, as I told, that we are doing in the seeing eye. So sometimes this laser, the lasers post laser, it ends with the staphyloma or the thysical eye or a painful blind eye. So one should be very careful about the written consent. This laser will act by destructing the ciliary epithelium, so resulting the decrease in the aqueous production, as well as it coagulate the ciliary blood vessels and the coagulative necrosis, which led to the ciliary body ischemia. The transscalar transillumination is necessary as the position of ciliary body many a time is variable, especially in the ophthalmic eye and the post-RD surgical eyes. A pop sound denotes the tissue disruption. If there is no pop sound, then we should increase the power to 100 to 150 micron, and the moment we heard the pop sound, again we need to reduce to titrate it. We should avoid doing this laser, destructive laser, at the site of where the sclera is thin or the previous filtering or tube surgery, and in the 9 o'clock and 3 o'clock position to avoid the long posterior ciliary nerves and arteries. As I already told, the complications are thysical staphyloma, distortion of pupil if we place the probe little anterior near to the limbus, formation of cataract or inflammations. Coming to the micro pulse laser, the company people is marketed it as a replacement of trabeculectomy, but it is not. Yes, it is much better than the earlier used cyclodestructive procedure. It delivers laser with the on and off time. The off time helps the tissue to cool down in between, thereby greatly reduces the thermal damage. It works much better than the previous cyclodestructive procedure, but the chances of hypotony, pupillary dilatation, bleeding, and the RD may be there. This is the probe for this is the G probe of micropulse. Now coming to the endocyclic cytophotocoagulation, it is a newer advance where we do the cyclophotocoagulation directly on the ciliary body. Coming to the conclusion, the laser in glaucoma is an important part of armamentarium in the treatment. Practical implementation depends on the result obtained on your own patient by trying different laser and should not rely on different studies, which is very few. The several situation exist when the laser therapy may prove beneficial to control the intraocular pressure in association with the medical therapy and may enhance the quality of life and improve functional vision. Thank you.
Thank you, Dr. Silpi, for a wonderful talk on laser procedures. In fact, we are doing cyclo-G as well as micropulse as well as SLT. And I find these two lasers adding to the treatment armamentarium in glaucoma treatment protocols. So moving on to the next talk, we'll have a discussion later on. So moving on to the main important talk on surgical failures, think ahead. And Dr. Mani Singh, who is a fluent speaker on glaucoma, also an avid practitioner of glaucoma. Usually when I get a little confused, I talk to him regarding any diagnosis of the treatment protocols also. So he'll be talking on the surgical failures. Think ahead. Dr. Manish, please.
Thank you, sir, for having me part of this instruction course. So I'll be speaking on the surgical failures, think ahead. So in next 10 to 12 minutes, I'll basically be discussing about why a surgical failure happens, how we can manage a failing bleb, and what are the future options, medical and surgical, when you have a failing bleb. When we talk about surgical failure, we mainly mean trap failure, but now we know we also have other surgical options like the MIGS and the glaucoma shunt surgery. So I'll be a little bit touching about those surgical failures also. On a philosophical level, I'll tell you, blebs don't fail, they actually heal. It's a natural healing process of nature. When you create a stoma, when you create a flap, over the time tissue will heal. And studies have shown that even the best centers that 50% of blebs, they heal by 5 years. So it's nothing unusual. What we aim in a glaucoma is a diffuse avascular bleb with pressure in early teens. But what we get, the reality is far from ideal. So what is important is that you have a meticulous follow-up of your trap patients. Try to detect these problems early so that you can manage them aggressively. The interesting thing about trap is that if you do the same technique in 3 different patients, you will have 3 different results. So it becomes very unpredictable at times, and it's not that reproducible like a cataract surgery. So very important in post-operative period, you evaluate the bleb, spend time with the patient, see the vascularity, what is the height of the bleb, what is the extent of the bleb, and very important, try to look for microcyst. If you compare these two bleb, this particular bleb has got multiple vessels. It's a formed bleb, but this is also a formed bleb with relatively avascular. So avascular bleb has a higher probability of surviving compared to a vascular bleb. This is a bleb which is failing. You can see multiple corkscrew vessels which have developed. Now they will cause fibrosis around the flap and the flow will be stopped. So it's a flat vascular bleb with no microcyst. In case you are not able to understand this cyst, you can use AIOC2024 or a UBM if available to see these small cystic area which basically indicate the functionality of the bleb. Now, why those bleb fail? The majority of the bleb fail because of the episcleral scarring, the natural healing which I was telling you. Apart from that, there can be other reasons like tight sutures, you can have a blocked stoma, or sometimes even a retained viscoelastic material may cause a failure of the bleb. So whenever you have a failed bleb, before starting any intervention, you should do a gonoscopy to see whether the stoma is patent or not. Because if the stoma is blocked, that blockage has to be removed. So this is a failing bleb. The pressure has started to increase. So how will you manage this? First, you increase your steroid to reduce the fibrosis. Give 5-FU injection. These are antifibrotic. We use mitomycin routinely in our trap patient. Even then, post-operatively, we do require 5-FU in some cases like these which are failing. Then you do digital massage to increase the flow through the scleral flap. And in case there are sutures left, you can go for a suture lysis or a release of releasable sutures. This is a case you can see the bleb is failing. You can see vascular with some blood also. You can see the releasable suture here. If you gently release the suture, you can just pull the end. And then little bit of massage, you will see the bleb will start to form. So these type of post-operative manipulations will definitely help you to prevent the failure. 5-FU injections are very useful, especially in cases of extensive fibrosis and congestion. We generally give 90 degree or 180 degree away from the bleb. Don't give it close to bleb because if by chance it goes into the anterior chamber, it will cause severe reaction and can lead to endothelial decompensation. In this case, you can see we are giving 5-FU injection. Try to avoid the vessels to prevent the chances of subconjunctival hemorrhage. After injecting using a cotton bud applicator, you can just gently spread it toward the bleb to reduce the bleb fibrosis. Tenon cyst or encapsulated blebs are also cause of failure. In this case, in early cases, if you can detect it, you can go for beta blockers and massage to prevent the failure. In later cases, you may require a bleb needling. So this example case, 8 weeks post-op, that is 2 months post-op, the pressures have started to increase. Now how we are going to manage? First, we'll start anti-glaucoma medication. Gonioscopy I've already discussed. You can consider needling to enhance the flow. Bleb revision, sometime we have tried, but somehow doesn't work very well with our hand. In case the bleb needling also doesn't work, the best option probably will be to go for a re-surgery, like a trabeculectomy again in a next site, or going for a shunt surgery. This is a video highlighting different types of bleb needling we can do in a trap patient and also in a shunt surgery. So what we are first doing, this is a patient where you can see there is a localized bleb, it's congested. So using a 30 gauge needle or a 27 gauge needle, we enter at least 5 to 8 millimeter away from the flap. And what we are doing, using the sweeping movement, we are trying to cut the fibrous bands, the episcleral fibrosis over the surface of the scleral flap. You can see that slowly the bleb has started to form. If you are seeing by cutting this fibrous band, you are not able to raise the bleb, you can use the needle to enter into the anterior chamber by lifting the scleral flap. And then you can increase the flow. You can see the bleb has nicely been formed here. This is a bleb. And then if suppose the chamber becomes very shallow because of this, you can form the chamber with air. And we are giving a 5-FU injection 180 degree away from the bleb. This is a case of tenon cyst using a 26 gauge needle. Again, what we are doing, we are trying to rupture the cyst wall so that the tenon cyst wall is ruptured and there is a direct communication of entry chamber with the subconjunctival space. So you are doing multiple punctures in the cyst wall. And once we have done that, you can see that bleb margin has become diffuse and it's a nicely well-formed bleb. This is a third case, a third scenario. Again, it's a trap done almost a year back. You can see a localized fibrous bleb. We are first trying to do needling superiorly. We are not able to lift the bleb. Sometime now what we can do, we can use a gonio lens. Nowadays, I think a lot of us have started doing MIGS. Using this lens, you can internally, using a spatula, try to lift the bleb. So you can see here, after doing internal, you can slightly lift the bleb, lift the scleral flap. And the last case I'd like to show about needling is a case of post-Ahmed valve hypertensive phase. The pressure has gone above 30 even on maximum medication. This case also you can do a needling, you can have multiple punctures. You can see immediately the bleb will start to form. Only thing, again later on the fibrosis may happen. So these cases have multiple puncture. Try to cut the cyst wall so that you can increase the flow of the bleb. In case your bleb needling has also not worked, even with medication you are not able to control intraocular pressure, then the option is to go for either a retrab or a shunt surgery. Direct cyclophotocoagulation is generally we reserve it for cases with poor visual potential. Surgical failure is not always raised IOP. Sometimes surgical failure can also be low intraocular pressure resulting in hypotonic maculopathy. These cases initially we try steroids and cycloplegic. If it doesn't work, the vision is going down, autologous blood injection can be tried. It works very well in certain cases, especially in early cases where you still have some vascularity left. But then the results are mostly short-lived. This is a case where patient had hypertonic maculopathy. We injected blood. You can see we are injecting, trying to fill as much area of the bleb possible with the blood. Once you see the blood starting coming into the antechamber, then you stop injecting. You can see the blood is coming. This is a post-operative picture. You can see the improvement in the OCT. In certain cases, you can even try compression sutures. In extreme cases of hypotony, post-trab, with necrotic bleb, you may even have to go for a scleral patch graft. Just touching a bit about the shunt failure, hypertensive phase is very common with valved implant like the Ahmed glaucoma valve. These cases, we try using aqueous suppressants and bleb needling. Sometimes bleb revision can also be tried. In cases of tube which are close to the cornea, you can have late corneal decompensation. In this case, you may need to cut the tube or reposition the tube into the sulcus or the pars plana area. Plate and tube erosion need to be aggressively managed to prevent any infection. In case like these, you will require a scleral patch graft with a conjunctival patch graft. There is a case of failed Ahmed valve. You can see superiorly there is a valve here which had failed. Now we are trying inferiorly. When you're going inferiorly, you can go with the FP7 or you can go a smaller version, that is the FP8, because inferonasally the area is small. So in this case, you can try a FP8 version also. Another important thing is when you're suturing, don't suture it beyond 8 millimeter or beyond 10 millimeter, because FP7 valve, if you're suturing too posteriorly, the posterior edge of the valve will touch the optic nerve and can lead to traumatic optic neuropathy. You can see the post-operative period. This patient we are following up for 10 years now, and they are doing very well with these two Ahmed valves. This is a post-trab failure. You can see penetrating keratoplasty done. Patient had a vitrectomy done also. This case, because a PK has been done, we are going with a pars plana implantation of the valve. In this case, you can use a normal FP7 or FP8, or the pars plana variant of the Ahmed valve can also be used. Nowadays, what we are doing in cases of Ahmed valve failure, like this is a patient, young one-eyed patient where Ahmed valve has failed, we are going with a RD or a Ahmed clear path implantation, because once a valve implant has failed, you can try a null valve implant. I won't go into the surgical details. I think we all know how the steps of Ahmed valve surgery. This is a post-operative picture. You can see this has been, I think, almost 3-year follow-up we have. So superiorly we had a Ahmed glaucoma valve, and inferonasally we had got the RD implant. Diet cyclophotocoagulation, cyclocryotherapy can be tried in cases of surgical failure where the visual potential is poor. I think Dr. Shilpi has already discussed them. Endoscopic cyclophotocoagulation has a better surgical rate, but the availability of the instrument is a problem. It's a very costly instrument. I think MIGS also is becoming popular now. MIGS, most of the studies are there for about 2 years. So if the pressure start to increasing, most cases you have to enhance the medication, or the best option is to go for a trabeculectomy. But there are reports where repeat eye stent or a GAT procedure has been done after a failed MIGS procedure. Macropulse laser also has been slightly discussed by Dr. Shilpi. This is a new technique, but then initially it was promoted for as an alternate to TRAB, but we found the results were not very predictable and short-lived, and there have been cases where vision has gone down also. But yes, it is definitely more safer compared to a diet cyclophotocoagulation. I'll just conclude saying glaucoma surgery is definitely far from being perfect. We have to be meticulous with all our patients, have a meticulous follow-up. If you recognize this complication early and manage aggressively, most of these patient eyes can be saved. And as a glaucoma surgeon, we need all types of weapon in the armamentarium, starting from trap to MIGS to shunts to needling. We should be aware of them so that we can use them correctly in the patient when it's required. Thank you so much, and my best wishes to all of you. Have a great time in Calcutta. Thank you.
Thank you, Manish, for a wonderful talk. One question.
Yes,
in
sir.
cases of trap failure, where we are going with a bleb revision kind of thing or needling kind of thing, should we add bang with... is there any study available with that?
We don't have any study like that. I think Dr. Satyan sir is there. Last time we had a meeting in Mumbai, and sir was sharing some experience where he has done I think eye stent with trap, sir, something like this. No, I think the question what Dr. Bibhuti sir is having in case of a failed trap, if you're doing a re-trap, whether it's justified to do a bang procedure or any MIGS procedure also.
Combined bang with that.
Combined. Probably, sir, there is no such studies like this till now. But sir was sharing his experience in a recent meeting in where he is trying a eye stent with a trap, a combination. So, sir, would you like to highlight something like this?
Yeah. So there is no any specific things that only you have to do it. You can do with a bang, you can do with a 360 GAT, you can do in the same site repeat trabeculectomy. There are various options are available for us, but only thing is it is a case-to-case basis.
There are no
because
proper
we don't
studies
have a
as such.
nomogram kind of thing.
Yeah,
What
yeah.
is going to happen with both the procedure doing same time?
Yeah.
It's quite difficult, but I'm doing combined trap plus the bang together.
So what a kind of result IOP reduction you're getting in that? And what are the common complications which you get in that?
See,
Trap with bang.
There is no common complications as such. It is like when you do the bang, like in other MAGS procedures, how you get the hypema, it is same as that. There is no big difference. But we are, as beginners, we are just trying to make sure that any one of these procedure really works for the patient.
Okay.
So that is the ultimate goal.
Got your point.
And now what we are seeing is definitely the IOP drop is much better than doing an isolated trabeculectomy or possibly isolated only a mixed procedure. But it is too early for me to just say everybody go and do that procedure.
Yeah, thank you. Thank you, Manish, for a wonderful talk. Next talk is by Dr. Mamta Singh, who is assistant professor at AIIMS Rajkot. She'll be talking on patient quality of life. That is also very important. Somehow, the glaucoma specialist and ignore that topic. Because that makes the life of a patient very difficult once he has started putting many drops and altering the whole environment of that ocular surface. So she'll be talking on patient quality of life.
Well, good afternoon, everyone, and thank you, sir, for making me a part of this IC. As sir said, I will be talking on the patient's quality of life, where exactly we stand and how to go ahead of this given situation. We all know that we have this huge burden of glaucoma patient. As a treating clinician, we all are aware of that. And even the government of India has realized that glaucoma is a priority disease, and it has been put there in the 12th five-year plan. So what is the goal of treatment? The goal of treatment is to maintain patient's visual function and the related quality of life at a sustainable cost. That is the basic idea. But when we say quality of life, it's a very individual concept. There is nothing like a universal definition of quality of life. For example, if a person of our society, say 75, 78 years of age, we do not expect him to go out, drive his car to get grocery from the local market. But if a person who is staying alone in a Western community, probably that is his necessity. So quality of life is actually dependent on the cultural and value system where the person is residing, or in relation to his goal or his expectation, or her, of course, standard and the concern. So it's not that we have one particular group of glaucoma patients. We are dealing with the entire spectrum. Few of them are totally asymptomatic. And on the other hand, we have patients who have been completely blinded by glaucoma. So if we want to talk about the quality of life of this entire spectrum, we have to have so many things in our hand. We need to understand the basic concept there. That is the entire idea. And glaucoma is one disease which has this huge impact on our life, be it psychological, social, and so on. So when we diagnose a patient with glaucoma, we all know that Google is something, gives left and right information. So this diagnosis, or this, the realization that the person is having a blinding disease, this is a major setback. And it has been reported that anxiety and depression is much more prevalent in this group of patients in comparison to the age-matched individuals. And as the visual acuity goes down, as the physical limitation sets in, this further increases. Some of the basic things that we take for granted in our life, like reading newspaper or crossing road, all this become, these patients probably need assistance even for those tasks. So this is really a difficult situation for them, the physical limitation which comes with the disease. And we have this questionnaire, the GQL15 questionnaire, which mainly is devoted for the physical limitation in this group of patients. And if we talk about the socio-economic factor, as I said, probably the social factor varies from in our society to Western community. But there is very common in the entire human population, that is aging. As the age increases, this hand-eye coordination goes down. We tend to be, more forgetful. So remembering that we need to put drop for the next 10, 15, 20, or 30 years of life at one particular time, this is a tough task for a person who has lost his hand-eye coordination. And this is probably going to make him dependent on his family, on his friends. And we have a very wonderful study from India when it comes to the economical constraint of these patients. There is this direct medical cost involved, where the patient is paying for the glaucoma medication, glaucoma surgery, or the hospital visit. Then direct non-medical cost is involved, the transportation or the nursing home care, and the indirect cost. That is what the patient would have earned on that particular day, or what the accompanying person would have earned on that day. More than 60% of these patients, they are using 2 to 3 glaucoma medication, and this is a big impact on the economical status of the patient, especially for a person who is belonging to low socioeconomic status. As sir said, ocular morbidity also it plays an important role. The ocular surface disease, it has been reported, the reported prevalence is 15% in individuals more than 65 years of age, but in similar glaucoma group of patients, it is nearly 60%. There is this constant sensation of burning, stinging, tearing, dryness, and even if the person gets operated, there is this constant foreign body in the eye, which is the filtering bleb. This comorbidity, in addition to the preservative, it is also due to the inherent property of this glaucoma medication. Of course, preservative play the important role because of their detergent effect, cytotoxic, and immunoallergic reaction. These are some of the examples that we come across in routine practice. So overall, the quality of life is going down. That is something we all have to understand, and we have different questionnaires. But what we need to have our own set of questionnaire, which is for our group of people. And what is the way out? How to go ahead with this group of patients? What will make their life a little easier? So if we talk about the psychological impact, we need to make the person understand that glaucoma is a potentially blinding disorder. Not every person who is having glaucoma is going to get blind. There is a potential of retaining the vision, whatever the person is having. And this we need to emphasize, this we need to talk about at every visit, not once, but every time whenever he or she comes for the follow-up. We have different low vision aids, so we need to have a contact number for a person who does all this, who does wonderful job with low vision aid. For example, if a person is finding difficulty in crossing the road, probably those peripheral field enlargers, that is going to help. So that is one solution. Similarly, we need to think about it. Then there are certain devices which are not available here in Indian market, but then there is this way. For example, if we talk about this picture, we can see it here, with the non-dominant hand, with the index finger, you just pull down the lower lid, bend the index finger at the second knuckle. The thumb of the dominant hand, it should be rested here on the knuckle. Rest the index finger on the forehead, and then change the direction of drop. There will be less of drop vestige. There will be more controlled drop application. And this is something we can teach our patients whenever they come to our clinic. Economical limitations, we all know fixed drug combination, and in addition to decreasing the cost, definitely they are decreasing the preservative adverse events. There are multiple available here in our market. I do not have any financial interest here. The another option is to decrease, for decreasing the ocular surface disease, is shifting to safer preservatives like Pure Eyes, Softgia, Polyquid, or completely preservative-free formulation, either single dose or multiple doses, like ABAC and Comod. We have Timolate in Comod form now. So ultimately, if we want to maintain the quality of vision, we need to make the person understand that it is the compliance which is going to play the important role. We have to emphasize, re-emphasize, and keep on emphasizing that unless the person follows our instruction, come for regular follow-up, nothing is going to help. And these are some steps, in my opinion, which can help in making their life a little more easier. Thank you, sir.
Thank you, Dr. Mamta, for this talk on patient quality of life. That is very important. When patients are putting multiple drugs, patients are usually older age. So that makes the whole surface as well as the quality of life of patients very poor. And that's where we need to take care of using the combination medicines to reduce the number of medications which we are prescribing to the patient, as well as we need to take care of surface also. So any question from the audience, else we'll close this IC. Just one question to Kumar Ravi. Ravi bhai, what is your protocol when you see a patient IOP going up? So how do you proceed in your day-to-day practice of dealing with that patient? So say patient is on 2 medications, and now what was the target IOP or the target range which you have thought of? Now that range is crossing multiple times.
So I'll share my protocol. What I do is, usually when I see a patient, I put up in my codes, like what is the target pressure for that patient. Say it is 16. I showed you in the first case. So it's 16. So it's there in the patient file, but not visible to the patient. Now, my drug of choice in most of the cases is prostaglandin analog. This is what I start with. I see how is the situation, follow up, keep following up with target pressure with perimetry, with disc evaluation, and everything is noted. If the pressure starts going up, I shift to combination. Usually it is with beta blockers. Then prostaglandin analogs. Then now earlier it was these three were there. Prostaglandin analog, beta blocker, alpha agonist. These are the three. And now we have one more, so we can add ROC inhibitors. Then these are the four. Like usually what I see is that after 3, I start priming the patient for surgery. 4th is just to buy time. And like after that, most of the time we see that will require surgery. The patient is not maintaining target pressure on 4 medications.
So by the time you prescribe third medications, you start preparing the patient for mentally for surgical procedures also. Either it is laser procedures or the surgical procedure.
Somehow I'm not very comfortable with the laser procedure. What I find is that like what works is trab. Second is valve devices, and now the promise is with the MIGS, like especially Bang, that probably has some promise if we successfully do it. LVPI is doing a procedure called GAT. GAT I have seen works very well, little technically difficult, and initial 1 month we have to struggle with high pressures, but after 2 to 3 months the pressure control is very good with GAT.
Dr. Maris, can I ask one question? Once the medical treatment fails and you are sure that this patient requires some kind of surgical intervention, how do you select your surgical procedure for that patient and broadly, and how do you motivate the patient or counsel the patient for that?
Adding to what Dr. Ravi was telling, that once you start going to 3 medication, so sometime now we also use 4 medication in 3 drops, like say a brimonidine with brinzolamide combination and a prostaglandin timolol combination. Once you go to that stage, we generally start priming the patient that you may require a surgery. The preferred surgery definitely is a trabeculectomy. That is, like prostaglandin is the drug of choice, trabeculectomy is the surgery of choice for most glaucoma patients. In case I feel that trabeculectomy has a poor surgical rate, for example, cases like say eye syndrome or aphakic glaucoma or say post-VR surgery glaucoma or a new vessel glaucoma, then we do give option to patient that trabeculectomy may not give you a good surgical. You can also consider this as a surgery. So this way we give option, but whenever possible, and if we feel trab can be done, we always try to do trab. But we always inform the patient that glaucoma surgery is not a one-time thing. After surgery also you need to be under follow-up. A lot of these patients will require medication in future. You may require resurgery. Plus we also tell our patient that 2 to 3% patients you may have a decrease of vision, maybe because of infection or suprachoroidal. So a detailed discussion and a proper consent form is given to the patient. We tell the patient to read the consent form. If you have any doubt, discuss with her. Always the option is given to the patient, and the final decision is always taken by the patient.
Thank you. With this, we come to the closer of this. Yeah. We are running short of time. Can this question be asked later on?
We can come and discuss.
Downstairs? Yeah, because the other people are there.
Yeah. Mostly these newer drugs are being promoted as an adjunct therapy, not as a primary therapy. Primary therapy will always be prostaglandin unless contraindicated. As an adjunct, you can use beta blocker, carbonic anhydrase inhibitor, brimonidine, and now the ROC inhibitors also. So they can be used. They have some long-term side effects. For example, reticular edema, early stage you can have redness. So it can be given as an adjunct to your patient and can be used in most types of patients. There are no clear-cut contraindications of ROC inhibitor unless it's a known allergy.
With this, we come to the end of this talk with IC, that is glaucoma medical management, failure and way out. And failure means that need to be identified earlier, and that's why the patient requires a regular follow-up. Thank you very much for attending this course. Can I have?
आधा घंटा 1 घंटा 1.5 घंटा 1 घंटा 15 मिनट